Hello, everybody. We'd like to welcome you to the 7th Annual SCADaddle Weekend. West Coast SCADaddle. My name is Ellen Robin, and I am a almost 14-year survivor. This year, I've been elected as the president of the board for SCAD Research, Inc. Oh, thank you. No, I don't know why, but it's crazy that I took that on, but I love it, and I'm very honored to have the opportunity to work for all of you and to work for me too. So tonight we're going to have a presentation from Dr. Patricia Best from the Mayo Clinic, but before that I just wanted to talk. First of all, we're very honored that we have quite a few of our board members. This year we elected almost a new board. Last year there were 4 board members. We now have 9 board members. And I'd like to introduce our board members. The Vice President is Cindy Adams, right there. Thank you. Our Treasurer is Nancy Hebert. Secretary is Terry Bell. Did she go to the bathroom? There's always one in the crowd. And then Charlene Barnes, who's not here, but she's supposed to be here. She's on her way. She's en route. Am I missing anybody else? Nope. Oh, yes I am. Bob Alico, he's our past president. Bob started SCAD Research, Inc. about 12 years ago. And Bob is what we call one of our SCAD angel families. He lost his wife to SCAD, and so he wanted to find answers, and so he started the nonprofit SCAD Research, Inc. Since 2011, we've donated $1.3 million for research. And hopefully this weekend we'll be able to add some more this year so that we can donate some more for research. So that being said, I'd like to, at this point, introduce Dr. Best.
Thank you very much. So I'm going to start with some basics on SCAD and kind of go through a little bit of what's been going on with SCAD research as well. So this was, I think, from Chicago, and this is, as Ellen said, the 7th year here in the West Coast, and it's been in Carlsbad and then down to San Diego. And so it's a different forum. I've never been out to the West Coast, so this is my first time here, but it's wonderful for it to be a place where everyone can get together and meet someone else who's had SCAD and see and hear everybody's stories and find a community of people to help and then also do something for research, so that's wonderful. It's been a really wonderful collaboration with the Mayo Clinic, and we've been really honored to be part of it. And so heart attacks can happen to anyone, but ask me about SCAD. And when you think about it, a lot of people who have SCAD, they go into the emergency room and they kind of get you don't look like someone who should be having a heart attack. And even after someone has had their event, if they have more chest pain and go back to the emergency room, I've heard people who've had SCAD been told, oh, you're just anxious. And it's like, no, you got to be taken seriously. And so that I think that one of the other key things is learning to advocate for yourself and really working to help everyone to really get enough knowledge and understanding of what you need to get the best health care for yourself. And so this is a lot of pictures of folks through the Mayo Clinic. You can see Dr. Galati, Dr. Hayes, Dr. Tweet, a number of different posters and presentations that have been done all on SCAD. And of course, this is Bob Alico, who's been honored through Mayo as a benefactor for all of the SCAD research that we've all been working on. So Our research aims at, through Mayo Clinic are to increase and disseminate knowledge about SCAD, design and conduct research using data from registries, and we're working on outside of registries now as well. Present at scientific, medical, and patient advocacy meetings to help encourage people to understand what SCAD is, understand that it's a different type of heart attack, understand how to treat it, and basically get everyone aware of it so that people don't get ignored with their disease. Publish in peer-reviewed journals, network and share on social media to help with providing a community and understanding with regards to this. Engage trainees and colleagues and build the future so that all the people who've been through Mayo, I know they all come away with a good understanding of SCAD, so that's been great. And we collaborate with others and builds really good networks of education and research. And so we're trying to fill the knowledge gaps and trying to work towards answering questions that are out there. And so there's been such a lack of knowledge that it's really come such a long way over the last 10 to 15 years. So basically, it's everything we can do to help improve the outcomes of patients with SCAD and their clinical care. So Dr. Hayes started with this in 2009, and she got approached from a number of women who were at Women Heart. And Women Heart, she had been involved with for a few years, and Women Heart, there were a couple of women who had SCAD and approached her and said, hey, nothing's been done on SCAD. Why aren't you doing something with it? And so she started to assemble a pilot study to see if we could remotely test patients who had SCAD and get more information by having people not necessarily come to the Mayo Clinic, but send their information so that we could build a virtual registry. And that's what we've done. Basically, the pilot was just 12 patients, and then it's been opened since there with genetics and a number of genetic studies that have been done there. We have a registry which now has over 1,500 patients. There's survey data, and basically a number of sub-studies have been done off of that where we've asked people to fill out questionnaires or get other information in it. So it's been really very helpful for learning about SCAD and trying to figure out what the best way to care for people with SCAD is. And so there's been some new publications in the past year. There's a number of different outcomes and atrial arrhythmias and the combination with SCAD. There's been also data on some of the genetics and more loci noted on genetic testing. One of the problems with SCAD of what we've learned is that it's not just one gene, it's multiple genes. And so that unfortunately there's never likely to be a one test to identify who has SCAD because it's multiple genes and there are multiple genes working together. And so we've published on that. And so back to a little bit about the basics. So this is an image, and I'm going to take this with me so I can kind of point a little bit. This is an image of what a normal blood vessel looks like down on the left-hand side. And then we think it actually comes from the inside out of an intramural hematoma where you can get blood that fills into the middle layer of the blood vessel. And then that can tear open because of the pressure in it. And it's completely different than atherosclerosis, which is plaque buildup of fatty lipids and other things like a more typical heart attack. So it's not at all like that. Up in the upper right-hand corner, that is an OCT image, so it's an image in the blood vessel that you can see, and you see the dark portion around it. That is basically where that intramural hematoma is, and you can see that that's separate. So what do we know? We know that the average person is 42 to 52 years of age, but we've seen it at all ages. We've seen it down into the teens and up into the 80s. It's about 90% women, and only 5 to 15% are peripartum. That's really important because the peripartum was originally what we thought most SCADs were, because that's where it had been described. And it was because it was such a rare thing for a woman to have be pregnant or just had delivered and had a heart attack, and so they get published a lot more case reports. And so it wasn't until probably around 2010 or 2011 that we started to get more information and more series on patients with SCAD. And what we've also learned is, although it can be familial and running around with in a family where more than one family member can have SCAD, it's really rare that it's in a family like that. And in those families, one family and another family who both have had SCAD in their family don't necessarily have the same genes. And so we've also figured out that SCAD isn't as rare as we thought it was. Some of that, I think, is because of how we used to look at someone having a heart attack. So back 20 years ago, not everyone would have gotten an angiogram with their heart attack, and so how would you ever know that someone had SCAD? And so that during that time period, a lot more people were getting fibrinolytic therapy, clotbuster medications for their heart attack, and then potentially got stress tests afterwards, and so they might never have had an angiogram, so you would never know. And so that now that we're doing a lot more angiograms, and we better know how to look for it, and we understand that you don't have to see that flap, but that it can just be that intramural hematoma, you can identify it a whole lot more. We still have debates sometimes. We're not 100% sure if it's SCAD. That happens. Someone else may have thought it was SCAD, we don't think it's SCAD, or vice versa. And so that there's still challenges with identifying whether or not someone has SCAD. There's also biases in heart disease populations where, again, younger women tend to be told that they're not having a heart attack. And so some patients may never have actually been treated for the heart attack. We now know that it's probably 1 to 4% of all myocardial infarctions, and it's the number one cause of myocardial infarction in younger women under the age of 40, and it's 7.2% of myocardial infarctions in women under the age of 50. So it's a high risk for younger women. So they typically present just like everyone else presents with symptoms of heart attack. Almost all of them have some sort of chest pain, pressure, some sort of sensation. And when we say chest pain, we mean anywhere from kind of the jaw, kind of down to the belly. And it can be in the arm, it can be all kinds of different places, and that's typical for any heart attack. About 40% present with an ST elevation myocardial infarction, 15% with ventricular fibrillation, which is a rhythm abnormality where someone can lose consciousness and have to be shocked back. And 25% is multivessel. Of these patients, about 20 to 30% report some sort of stress trigger. So with this, we've heard all kinds of stories of family issues, the dog dying. That's actually a common one I've heard several times over, is the pet issues, lots of things with major stressors, someone at their daughter's funeral, that would do it for me, but it can also be physical stressors of running a marathon, other big physical stress. And so, but not everyone we find a trigger on. Some people will say, oh, it was a stressful day, but it's always a stressful day, and not really know. Typically, the stents that we usually use can be appropriate, but not necessarily appropriate, so that in someone who has a completely blocked artery, we tend to try and get that open. If there's still good blood flow, we tend to try and leave it alone, because many of these will heal on their own without any kind of intervention. And so that people need to be kept in hospital longer, we watch them longer if we didn't put in a stent. About 20% of people who present with their SCAD will have a normal troponin on the first blood test, but they'll have a lot of chest pain, nausea, vomiting, shortness of breath, and sweating, which is pretty typical for a group of people who are coming in with a heart attack. In men versus women, about 10% of the people who come in with their heart attack are men with their SCAD MIs. They tend to be younger, they have less FMD, they have less migraines, they have more exercise-induced cause of their stress, less emotional triggers, and they tend to have less chest pain post their heart attack, but similar MACE, which is major adverse cardiovascular events. So their outcomes tend to be about the same. So someone's had a SCAD event, what next? Well, early therapy after SCAD, we have seen in one retrospective study an association with lower recurrence. So many of us will try a beta blocker for at least a year. Blood pressure, we want to be pristine, because when you think about a blood pressure, that's going to be a stressor on your blood vessels. And so that you want to keep the blood vessel with less stress from high blood pressure. So not only do you want what's not considered hypertension, but you want it even a little lower than that. We don't use statins routinely, so statins are medications to lower cholesterol, and normally all of the cardiologists want to put it in the water and have everyone treated for their cholesterol, especially anyone who's had a heart attack. Well, that's only the good old atherosclerotic kind of heart attack where, yes, then we should put it in the water. But it's really reserved for those patients who otherwise should be on a statin anyways because of high cholesterol and preventing problems. But it shouldn't be used routinely as part of the care for a myocardial infarction. Then there's other medications that can go along with. If you got a stent in, then you'll need to be on aspirin and another antiplatelet agent such as Plavix. And if there's heart failure or other things associated from the heart attack, then we need to treat that. And then if there's angina or depression, we also want to be treating that. Sex hormones such as oral contraceptive pills, postmenopausal hormonal therapy, we typically avoid. Some of the avoidance to this really is because we just think that keeping things more natural probably makes sense, and because of the issues associated with pregnancy and a lot of the hormonal change times seems to be associated with it, but there's not huge data on that. And if someone's on triptans for migraines, we usually stop those as well. So you'll hear a lot about fibromuscular dysplasia. And fibromuscular dysplasia is a vascular abnormality. It can be in any blood vessel system, and it's an arteriopathy, so any set of blood vessels. And it was described as a bead of pearls, and you can see in the bottom right-hand corner what that looks like. And if you look at it under the microscope, the middle layer of the blood vessel is disorganized, and normally they kind of come into little sheets of cells, and this is just all over the place. And so basically, as the blood vessel developed, it didn't know to have the cells line up in the appropriate way. And so we find fibromuscular dysplasia along with in pretty high rates. It depends on the study and how hard they were looking for it. So it's somewhere probably in the 70% range that you will see it. And it's not due to plaque or other inflammation. It is, again, probably how the blood vessel has developed. It can be associated with high blood pressure, particularly when it occurs in the blood vessels to the kidney. Is also associated with headaches, migraines, and ear ringing. So this is, again, what fibromuscular dysplasia looks like. And if in a sub-study from Mayo, we looked at, for fibromuscular dysplasia off of CT scanning, and there was 66% had some sort of arteriopathy, 45% had multifocal fibromuscular dysplasia, meaning it's in multiple blood vessels. And with this, you find a number of different vascular abnormalities. So when we're looking at CT scans and looking for other vascular abnormalities, a lot of times the fibromuscular dysplasia is actually pretty mild, and it's not going to cause significant problems over the years. Sometimes it's more significant. But the things we really want to know about are dissections and pseudoaneurysms, where you can get a bulging of the blood vessel, or other problems that are associated with the blood vessels, and so that we're really screening for any kind of blood vessel problem. So again, the indication when you're looking at all of the imaging is not to rule out fibromuscular dysplasia, it's really to look for any kind of vascular abnormality, some of which are more important than fibromuscular dysplasia as far as risk and what we want to do and follow for it. So what kinds of symptoms do people have after SCAD? Well, chest pain is actually fairly common after SCAD, and a number of people have chest pain, and it's hard sometimes to figure out what the cause is. So oftentimes you need to relook to see if there's a problem with the stent, if someone had a stent go in, find out if they're having a recurrent SCAD, do stress testing if needed, and determine whether or not someone's responding to nitroglycerin. It's amazingly common, 30 to 70%. High rates of visits to the emergency room. And one of the things is, it's not just women who have SCAD that go to the emergency room after their heart attack as a recurrence. Many people who have heart attacks for any cause, all of a sudden, any chest pain you feel, you get worried about it. And so that is a fairly common occurrence. And so there can be many causes to it: chest wall pain, non-cardiac restenosis, or a problem within the stent, newer recurrent SCAD, pericarditis, so that's inflammation in the sac around the heart, or endothelial dysfunction, where you can have spasm of the blood vessels. There's also a type of angina where it cycles with the menstrual cycle, and that's very common and treatable, but it's not normal. So you don't call chest pain after this normal, we call it something that we need to figure out. Mental health after SCAD and why it's important. And we've looked at patients who've had SCAD and tried to look at whether or not they have more anxiety and depression and post-traumatic stress disorder associated with it. And what we found was that SCAD was considered a traumatic event by most, so 82%. The only or most impactful trauma that someone had ever had was in 74% of the people. 16% had at least moderate anxiety or depression, and 28% was having at least mild PTSD, with about 95% of people having symptoms weekly and 86% having symptoms daily. And so that's a huge kind of population that's getting symptoms associated with their event that you might not think of quite as directly with the event, but it has major implications. What we know in patients who've had a myocardial infarction, and these are data not from people with SCAD, just from any myocardial infarction, there's a rate of depression of 18.7% in this study, and that runs pretty similar to other studies of post-myocardial infarction depression. And the mortality, if it's treated, is the same as what it otherwise would be, but if it's not treated, the risk of dying within a year is significantly higher. And so that it's really important to try and treat symptoms of anxiety and depression and PTSD for both quality of life as well as quantity of life. So what about pregnancy? We see a number of young women who have SCAD and they want to get pregnant. And sometimes you're telling someone who's in their 20s, you've never had a child and you probably shouldn't have a child. Well, we did look at those patients who had gotten pregnant, and we had a little case series where only 1 out of 8 had recurrent SCAD. And so we had debates of how we would describe that in the article, because it was like 1 out of 8 was much lower than what I thought it would be. But yet it's still significant, because pregnancy-associated SCAD has usually worse outcomes with a lot more proximal dissections, so in the main blood vessels. And so these women can have a lot of issues with it. One of the other important things was about 1/3 of the patients had not been diagnosed with SCAD initially. And so that they were diagnosed with things like spasm of the blood vessels because someone hadn't made the diagnosis. And so the more we understand about SCAD and the more we can identify it, it's really important, because then you can educate people on what's in their best interest for their health. So we also looked at those patients who had pregnancy-associated SCAD, and they were more likely to have an ST elevation myocardial infarction, so a bigger heart attack. They were most likely to be within the first week after delivery, so not during pregnancy, just right after delivery. And they usually had a little bit more severe disease, more left ventricular dysfunction. It tended not to be with the first pregnancy. It tended to be someone with higher age, a little more infertility treatment, possibly associated with preeclampsia, and they tended to have less fibromuscular dysplasia and other vascular abnormalities. So whatever the trigger to it is probably enough to overcome some of the lack of vascular abnormalities. So the recommendation is not to get pregnant, and that will continue to be the recommendation for now, and to use effective non-hormonal contraceptives and prevent pregnancy. But some people don't listen, and we understand, and some people still will have a baby. And you get to make that choice, and so most will still tolerate pregnancy and lactation after SCAD without a SCAD recurrence, but 8 to 12% will. So we'll continue to discourage it, but if you're considering it, you want to have good counseling beforehand, discussion on what medications you want to be on, and that you need a good cardio-obstetric team to help with the delivery and making planning for everything. You want to talk about uterine bleeding and issues related to the DAPT, considerations of fibromuscular dysplasia, the migraine management, psychosocial burden, and losses and change to your lifestyle associated with having been diagnosed with SCAD. What about exercise in SCAD? And after a heart attack, we usually get everyone into cardiac rehab and encourage exercise. Well, there are certain things that are good for women with SCAD. We encourage cardiac rehab. Some people have not liked cardiac rehab because they were very fit women to begin with, and were not given instructions on how to get back to that same level of exercise, and were slowed down quite a bit in cardiac rehab. But it can be really helpful for giving you confidence with exercise. It's feasible, it's safe, it improves stress and helps decrease depression. We want women with SCAD to avoid competitive sports, endurance, high intensity, and in extreme temperatures. Strength training is fine, but you'd want to do it where you're not doing what's called a Valsalva maneuver. So that's basically the muscle man shouldn't be doing that. So I always say if you can talk through it, then you're not straining like that. So anything you can talk through, you're allowed to do. So that's the avoid straining prolonged Valsalva. And so aerobic exercise, again, any kind of aerobic exercise with common sense, so not too cold, not too hot, avoiding going to high altitudes without giving yourself time to change and get used to the higher altitude. Weight training can be done, but again with more repetitions and slowly build yourself up. You want to not do high intensity exercise where you're doing contact sports or really competitive sports. And you want to do things that protect your neck and head positions because of the possibility of that causing problems with your blood vessels to your brain. And so anything that has sharp pulling, so bungee jumping, probably keep that to a minimum, but those kinds of things. And so most people, that's not a big deal. Sometimes that is a big deal depending on what people want to be doing. So the overall advice is avoid pregnancy, use effective non-hormonal contraceptives, good blood pressure control, avoid triptans for migraines, psychological support, and that's really important. It gives you good outcomes. And consider genetic consultation with an arteriopathy gene panel. Also, everyone with SCAD should have had scanning to look for other vascular abnormalities. You want to eat a healthy diet, but no specific diet has been associated for SCAD, but it's part of a good healthy lifestyle. Again, keeping alcohol to a minimum and caffeine to kind of normal healthy levels. There's no supplements that have been shown to be helpful. Managing menopause, basically there's a lot of non-hormonal options, and so that there's lots of things to do, and so you need to make sure you're talking to a doctor who will help you with those symptoms. Some of the topical hormonal therapy is still appropriate because of the low levels that get absorbed, and so that can be very safe. And then sex after SCAD, that is okay. And so I'm going to quote Sharon Hayes on this one, and I threatened her that I would quote her on this one. So the sex after SCAD is, she said, sex is about 5 METs when done with a stable partner, and that's about the same as mopping the floor. So if you can mop the floor, you can have sex. And so that's my Sharon Hayes quote for the day. I thought that was pretty hilarious. So usually there's concerns about having sex after someone's had a heart attack. Really, it's kind of getting comfortable to things and giving yourself a little bit of time to deal with the stress, anxiety of it. If you're getting back into cardiac rehab and other things, then you'll also be able to know that if you're getting up to 5 METs, you're probably good to go. Or if you can mop the floor. We know that now, having had registries of SCAD, that there is a recurrence rate. They used to say it was like lightning striking, and so you'd never see it again, and you didn't have to worry about it after that, and we know that's not true. There's about 2 to 3% per year. The median time is about 2.8 years. It typically occurs in a different vessel, and so it's not a vessel problem, it's something else. And there's no protection by stents or bypass for the recurrent SCAD. We now have over 1,500 angiographically confirmed SCADs, again with questionnaires and personal data, and we're continuing to follow that with more data. We also have seen a huge number of patients at Mayo, and then we've continued to work on genetics, echo, proteomics, and microbiomics. And we currently, this is one of Dr. Tweet's studies. It's a prospective SCAD neurovascular project that she's working on in collaboration with Dr. Joyner and Dr. Baker, looking at other vascular and autonomic function in patients with SCAD. So trying to understand more of how the vasculopathy and how the vasculature is working in these patients. And so this is really a group sport, is working on SCAD and SCAD research. It's everybody's doing their own part, and everyone's working together to get to the same final goals. And so we appreciate everything that you do, and all of the education that we can do and all of the fundraising is really helpful from all of the standpoints, so thank you very much. And I think I just have a few little questions. So I would be happy to take questions if anyone had SCAD-related questions.
So would that be a no to IVF after SCAD with a STEMI? 2 weeks later for me, she said that she was 30, she's 38 now and she was 37 when she had her SCAD.
No to IVF?
IVF.
So we would discourage IVF because IVF has been associated with greater risk of pregnancy-induced SCAD. It's hormonal therapy. And so for all of those reasons, we would discourage it. That does not mean that someone may not choose to do that anyways, but no one's going to recommend it.
For the recommendations for exercise, is that just for forever for anyone with SCAD, or you can slowly start to work up to some things? For example, like the yoga.
So yoga is not yoga, you know, there's different types of yoga, right? So you know, hot yoga, probably not, you know, things, basically, it's, when someone tries to tell you how much you're allowed to lift for strength training, no one should ever give you an exact amount of weight, because as you continue to exercise, you get better at it. The same is true for yoga. And so that as you're continuing to do things, you can hold things longer, again, without straining as much. And so it's mostly trying to listen to your body and trying not to strain and other things. And so you just don't want to be holding your breath for long periods of time. And so that's primarily the yoga answer. So, you know, gentle yoga. Lots of us can do that. The more complex things, you have to kind of just take it a little slower than everyone else and build yourself up slower.
Okay, so I've started exercising with Orange Theory a year ago. So I'm 5 years out. Mm-hmm. But what I've noticed is I usually have a really low blood pressure, mm-hmm. low heart rate. But when I'm working out, it can be like 170.
So blood pressure when you work out, everybody's goes up when they work out. So that's normal. 170 is still going to be normal.
Okay.
So in order to have exercise-induced hypertension, it usually has to be higher than that. So there is an age calculation to all of that. But 170 wouldn't surprise anyone.
Okay. And then my second question is, I have 2 daughters. Mm-hmm. Is there any way of knowing if they're at risk?
So usually when someone does genetic testing looking for vascular abnormalities, vasculopathies that are genetic, it's only if you find something there that you will better know for what to screen your daughters for. Otherwise, we don't have any specific things that you need to be looking for.
Okay, so, and I did read an article that there was some genes that they had done some testing and
Yep.
they thought that there was some connections.
Yeah, so there's been some genes that have been identified, but they're not yet something that's diagnostic for SCAD. So that when we find some genes that are associated with it, it's not like you can go in and get that one blood test and know for sure if you're going to have SCAD. And so that it's, unfortunately, it gives us hints at it, but it's not yet something, especially when there's multiple genes involved, that it's easy to make a diagnosis with.
I had my SCAD in 2006, and at that time I had a quadruple bypass, and I didn't see anything about the percentage of people that have bypass surgery.
Yep, that has probably changed over time, and so that I suspect that surgery is going down with SCAD. One of the reasons that it's not as ideal is because the grafts will close over time or can close over time, and so that there's a much higher risk of grafts closing in someone with SCAD. What happens is that in order for the graft to stay open, your body needs to need the blood flow to go to that area. And if the SCAD area heals up, which the majority of them do, then that graft is no longer needed, and so that there isn't good flow down it, and that makes the graft close up. And so that we know that there's a high risk of graft closure, and so that's one of the reasons we usually try and avoid bypass surgery if at all possible. But if someone has very proximal disease, large dissections, other things, then sometimes that's just what you need to be doing. And so we still will send people for bypass surgery. It's just not as common, and so it has been going down in frequency.
So there's a couple questions here that are asking for personal, and I just wanted to, unless you want to answer them, but usually Dr. Hayes doesn't ask, they're asking, I can ask you if you want.
I'll try and make it more general if I can.
Okay. So I took triptans for 6 years to treat migraines, stopped taking them in April of 2023, and had my SCAD STEMI late May. Is there any evidence that long-term use of triptans weakens the artery wall? If so, is there any knowledge about strengthening of artery walls after discontinued use of triptans?
So there's no data on that. Triptans, we know, can increase constriction of some of the blood vessels, and so usually are discouraged because of their impact on the blood vessel wall. And so usually anyone who's had a heart attack will usually stop the triptans.
I have more here, but there's inside. Who else? Oh, there we go. Here you go.
Thank you. I have a couple. Since we're not supposed to exercise in heat, can we do saunas, like infrared saunas, or saunas out? Like,
Usually shorter periods of time, and so, you know, basically all of those things to just keep things more limited in time frame.
okay. You mentioned something just at the very beginning about arterial arrhythmias with SCAD.
Atrial arrhythmias, yep.
Okay. Irregular heartbeat,
Yes.
right? That's happening.
From the top of the heart, yes.
Okay. Can you tell us any more about that?
So higher frequency associated with that, yes.
And we need to be concerned if we're feeling that and it's happening, or
So something to be treated, basically, if it's happening.
okay, one more. Sorry.
Okay, sorry.
You told us to advocate, right?
Yes.
And what is a way, since you're a cardiologist, can I ask this? What is a way to how do we advocate for ourselves and also bring cardiologists updated info? Where do we?
Yep.
How do we do
So the first thing is that any doctor you have should be open to you getting a second opinion if you have questions or some concerns over care. Even being at the Mayo Clinic, I still have people who say, hey, I want another opinion. I help them get whatever opinion they want. And if your doctor's not open to that, then that should be a concern. And so that, I've gotten second opinions for patients within Mayo and outside of Mayo. And so, so that's one thing. Advocacy sometimes is really important in the emergency room. And that's one of the places that I just hear it so often where you're like, someone wasn't taken seriously, and sometimes you just need to be pushy of like, well, what's my troponin show? Oh, it's, no, we're not going to leave after just one. We want a second one, right. And so sometimes just questioning. And then oftentimes actually, doctors who don't know a lot about SCAD oftentimes are really thankful when someone gets a second opinion over with the SCAD clinic, because then they have an outline of what to be doing. So I hope that was helpful.
Here's a question. What do you know about COVID and SCAD recurring?
So, so there's not great data. There have been case reports published of people who had SCAD along with their COVID. There isn't a lot of information on how that interacts. So it is a stressor to the body to have COVID, as well as an inflammatory disorder, and so that can put you at higher risk for a myocardial infarction. So that's one of the places that we know, and so that just like anyone else who's had a heart attack, we usually encourage people to be protective of themselves regarding COVID.
Hi, nice to meet you.
Nice to meet you too.
I was 38 when I had my first SCAD and my only SCAD that I'm ever going to have. It's not going to come back. And I've it's been 10 years, medically treated. I'm totally fine. Haven't seen my cardiologist since, but I'm on baby aspirin and lisinopril since for the last 10 years. Can I ever come off of it?
So, aspirin is having a greater debate right about now. So, some time ago, I would have said on the aspirin front that there's no data on the utilization of aspirin other than if someone has a stent, and that all the SCAD groups are doing it. There was a retrospective study that looked at patients on dual antiplatelet therapy versus not, and showed increased risk of recurrence associated with dual antiplatelet therapy, and that all of a sudden got everyone worried that maybe aspirin's not such a grand idea. And so there are trials ongoing that are looking at aspirin. So this far out, I don't know that there's any clear benefit to being on an aspirin. Lisinopril will have two benefits for you. One is if you had a big enough heart attack that it affected your heart pumping function, and if that was reduced, we usually leave you on lisinopril. If it was a small heart attack and that didn't occur, then we don't. Then the lisinopril is also, it lowers your blood pressure. And so if you need it for lowering your blood pressure, then that is also helpful from that standpoint. So those are my answers, and that's as generic as I can make for answers on all of those fronts.
What percentage of dissections never heal?
We don't know that for certain. We think it's probably down to the 10 to 15% range. So the majority of them seem to heal. How we have data on whether or not dissections have healed is that someone who's had a dissection, if they went back and had another angiogram for another reason, we've looked at it. So it's fairly low, but it's not 100%, and so we have seen dissections that persist.
Okay. Understanding that there is a lot more research that needs to be done and is currently being done, there are so many SCADs that are not FMD or vascular abnormality related, and given the recommendations for no hormone replacement therapy and the postpartum patients and the age range of 42 to 52, can you speak more to this thing that comes out of nowhere, and is there research and more known about, is this hormone related? Like, why does this dissect out of nowhere if you don't have vascular abnormalities? Like, can you speak a little bit about what the aims are with research related to that?
So there are definitely there's a lot that we don't know. And I always think that there is a systemic factor, systemic meaning throughout the body factor, that's going on when someone has a SCAD event. So we think that there's something triggering it, and so that when you think about it, why would you have a dissection in two different coronary arteries that aren't like physically located right next to each other? And then we've also seen patients who had a dissection in their heart along with a dissection in another blood vessel at the same time. Okay, so that there's something systemic going on. And we think that it's probably in people who have weaker blood vessels associated with some sort of triggering event.
So when you say systemic, are you talking about like catecholamines and stress response hormones, or like when you say systemic, like?
So systemic means something throughout the body.
Right.
Now what that is, I don't know. Okay, so I'm not going to make you more satisfied, sorry. But things like catecholamines would be a systemic response. You are correct on that. So understanding what things that could be throughout the body that could be triggering it. And so that's why some of the information, like trying to figure out better how the catecholamines are working, like Dr. Tweet's next study is looking at some of that to see whether or not people with SCAD have some differences in some of their autonomic function is important.
Thank you.
Can you talk do you have any connections with esophageal spasms and SCAD?
Not that I know of. Sorry.
That was not the answer I was
So just because I don't know of any, so it's hard because the answer is sometimes people just have two different things going on and it just happens. And whether or not there's an association, I have no idea. I haven't seen anything written about it, nor do I know about anything, but I also don't know that anyone's ever looked. You had a...
Oh, hang on.
Can you guys hear me okay?
No, they can't on the video, though.
Sorry, Ellen.
Oh, that's all right.
You're having it back here. So my question is, you were talking about troponin levels. And I remember something you brought up, and you mentioned it tonight too, the first time when I went in, my only SCAD. Initially, they were like, oh, you're fine. And then they ran another test like 2 hours later, because I said, I do not feel good. And then the troponin levels were much higher.
You were in that 20% group who their initial troponin wasn't positive.
They said, you're fine, just,
Yep.
And I was like, I'm not going anywhere. There's
Yeah,
no way.
just
I
no.
never remember those few hours, but I just remember I wasn't leaving.
No, right, yeah.
So what is that's called a normal heart attack, not a SCAD heart attack? When you go in for a different type of heart attack, are your troponin levels instantly?
No.
So it could happen, okay, so, because
So
they
it's
look
the
at you
same
like you're
thing.
kind of, okay, so it's the same thing.
So it's the same thing, but they eyeballed you and said you're a young woman who doesn't look like someone who should be having a heart attack, and your initial troponin was fine, so I'm not going to worry about it, and so
Exactly.
you shouldn't either. And so so this is what I was talking about of
They
advocating.
give you the look, that you
Yeah.
get that look, like,
Yeah,
you're fine, right?
yeah, no, right.
Okay.
Somebody said that, and maybe they're right, I'm not sure, that they're saying that a non-STEMI is small and a STEMI is big. Is that, I mean, I've heard it different than that.
Yep. So a STEMI is an ST elevation myocardial infarction. So on the electrocardiogram, the little blips, one of the areas is elevated. Okay, and so that's how you see that it's an ST elevation myocardial infarction. And so you can see it off of the ECG. And traditionally, when someone has that kind of heart attack, they need to go get treatment right away. And so typically, we bring people to the catheterization laboratory. If not, they might get thrombolytic therapy if there's someplace that they can't get to a cath lab, but most of the time people go to a cath lab. And those patients need to go right away, and so that we have parameters by which we get people to the cath lab in pretty short order. If someone's having a non-ST elevation myocardial infarction, they're more likely not to have the blood vessel completely occluded, and it might be opening and closing and other things. And so that on the EKG, it could be normal. It could have ST depression, so the one segment can be dropped down. It can have some flipped T waves, so one of the humps can be looking funny. So it can be anything off of the ECG. And more typically, those patients, if they can settle out with medications, they can wait and have their catheterization done a little bit later. So typically, the size of the heart attack is probably smaller with a non-ST elevation myocardial infarction, but it also depends where in the blood vessel it's coming from. So it could be a smaller branch that could cause an ST elevation myocardial infarction, and a bigger, more proximal area that's causing a non-ST elevation myocardial infarction. So it's not quite as clear on that front.
Yeah. Any more in the room? Yep.
Hey, thanks so much, Dr. Best. I think this was a great presentation, very enlightening. Appreciate that. You had a slide about chest pain, and I had a question about that. My wife had her SCAD 3 months ago, and chest pain is something that's kind of bothering her. It kind of goes up and down on a day-to-day basis. So wanted to understand, are there any specific tests that you recommend to go after to chest after that chest pain, or is it something we expect to get better over time?
So if someone's having chest pain after their SCAD, then you should be evaluated for that, okay? The evaluation can take several forms, so a little bit depends on more how your symptoms are presenting. So you can look for pericarditis, so inflammation around the sac of the heart. You can get that with a heart attack, and so that's usually a more constant kind of pain. and typically alters with breath holding, but doesn't have to. There's chest pain that comes more around menstrual periods. There's chest pain that can come from other things and blood vessel reactivity, and so that some of it has to be doing further testing to look for other causes, and then some trials of medications typically, whether or not nitroglycerin makes it better, et cetera, to try and figure out the cause. It also is important to make sure that there's no issues related to the blood vessel that was the cause. So sometimes if the blood vessel wasn't treated, so whether or not the dissection persisted, or if a stent was put in, whether or not there's a problem around the area of the stent. Okay.
Any more in the room? Oh, coming.
Thanks for taking my question. Mine left permanent damage in my left ventricle, and my question is, I'm unwilling to accept permanent. Is there any research being done that could possibly revive these areas, or surgically, not so much with medicine?
Yep. There's been lots of work trying to, get part of the heart to grow back. There are not things that are there yet, but there have been a number of different stem cell studies and other things working to try and make that happen. So I don't know if and when those things will actually happen, but there's certainly been research on that. It hasn't been related to SCAD, but just related to heart attacks in general. I know that there's a study that's starting at Mayo related to congenital heart disease, where the heart muscle is weak related to those kinds of things. And so, and, so there's all kinds of different options, and, cardiology and medicine in general has been changing so rapidly that it's amazing what 5 years will bring, or 10 years, and so that you have to be a little bit in awe of what kinds of things can be done now that weren't ever possible before. And so I don't know what's going to come with that. I know that things continue to improve as far as different things that can be done to left ventricular assist devices, cardiac transplant, other things that can be done to help along the way. And some of the newer medications have been really helpful for people with heart failure.
I have one question. What are your thoughts about antidepressants being heart protective?
Antidepressants haven't been shown to be heart protective except if someone is having depression. So that putting everyone on an antidepressant isn't necessary. It's really only if that's treating someone's depression along with their heart attack.
It was in the slides and someone else just brought it up. Can you speak a little bit more about the whole menstrual cycle related angina and?
Yep. So I've cared for some of these patients, and they will come in and say, a couple of days before my period, I start to get chest pain, and then, somewhere partway into my period, it goes away, and it happens every month. And we know that that's along with some hormonal cycling and other things, and so that we sometimes have people who go on medications just certain times of the month, so that they won't get angina during those times of the month. And so it's a known phenomenon. Yeah.
So just documented, but still something that we don't have a connection or is related to the research being done on the other hormones.
Yep.
If you have a SCAD and an aneurysm with it, will the aneurysm go away?
So aneurysms are not associated with the SCAD location of where the dissection was. If someone has an aneurysm, it's found in a different blood vessel. So the aneurysm doesn't go away. An aneurysm is an outpouching of the blood vessel from the blood vessel wall being weak. And we know that if they get to certain sizes or other things, they're at risk of tearing and causing bleeding. The place that we think about it the most is up in the brain. And so that there are ways to treat that. They can do surgery, they can do coils, they can do some stenting, they can do other things. And usually it depends on the size of the aneurysm, the location of it, and it's usually following with serial imaging to see if it's getting bigger or what's happening with it. And so it's not usually at the site of where a dissection is.
Dr. Best is truly the best. Greetings from Delaware. That's sweet, thank you. And then also, there was a comment to Dr. Best that said that this was more informative that they got from going to their cardiologist, so.
Very sweet as well. Thank you.
Exercise limitations post-SCAD. Can we do planks, push-ups, etc.?
So again, it all depends on where your fitness level is. So there's nothing wrong with planks, but there's lots of different ways to do a plank. You can do it slightly elevated, which makes it easier to do. You can do it on your knees. You can do all kinds of different things to make a plank easier. Lord knows I know that you can make planks easier. And so basically you want to do it until you're, do it in an easier form until you get good at it. And you basically want to still be breathing through it. And so as long as you can talk through it and breathe through it, you're okay from that standpoint. It's only when you're holding your breath, bearing down, all of those things that you should not be doing whatever you're doing. And so planks and push-ups, it really depends on your overall fitness level.
Okay, great. Here's a question from Andre. Blood pressure medications. How do you doctors decide which blood pressure med is right for a female SCAD patient?
So most people would pick a beta blocker to start out with because of the one retrospective study that suggests benefit in patients with SCAD as the first choice, and then depending on if there was any drop in the heart pumping function, then something like an ACE inhibitor or angiotensin receptor blocker would be a good choice. And then after that, it really is more random of what other things you think might be helpful.
Okay, great. By the way, we have greetings from Northern California, Colorado, Florida, Australia, Minneapolis.
Wonderful.
Canada, Brisbane, Australia. So what would that be a no to IVF after SCAD with a STEMI? 2 weeks later for me, I am 38, I was 37 during the events.
So there's several issues associated with that. When the first thing is IVF, when the general recommendations are not to get pregnant, IVF is a rougher through pregnancy because you're basically doing hormonal stimulation to get yourself pregnant, and so that it's hormonal activity of pregnancy on steroids, so it's superdosed. And so there's that. And then someone who's had a heart attack, depending on whether or not they have a stent and how the heart pumping function is, that there would be concerns with that. So you're not going to find anyone who's going to say, hey, this is a great idea. With that being said, people do what people do, and so that the recommendations are always not to get pregnant after a SCAD event. IVF would probably be even increased on that level. Talking with an OB who has lots of knowledge on that, maternal fetal medicine, they can help with decisions on that, but generally the answer would be to discourage that.
Okay, real general question. What kind of symptoms are folks generally having daily?
So most people who've had a SCAD event, it usually comes out of the blue, or that they had some warning signs like the day before or hours before. So it's usually a sudden onset of symptoms. And so usually there's nothing that leads up to it. After a SCAD event, some people will continue to have some chest pain, and that's what we talked about with wanting to make a diagnosis of why they're still having chest pain, and that it's not normal, but we see it often enough.
Okay. Just a few more. Any precautions for a pregnant daughter to take who has a mother who had a SCAD and has multiple arteries with FMD?
No.
Okay.
On that front, the answer would be to make sure that the OB is aware of that, and then there's certain precautions of what we do in someone who's had SCAD, of medications and lack of medications for the event.
Okay, great. And that's it. We're all caught up.
So we just want to thank you so much, Dr. Best, for being here, and
my
thank you
pleasure.
all for coming tonight, and really a special thank you to Ellen
Yes,
for helping coordinate and plan this for all of us. Thank you. Thank you, Dr. Best.